Hello, good afternoon, and welcome to the 7th meeting of the All Party Parliamentary Group on Axial Spondyloarthritis. And the theme for this meeting is Axial SpA and Primary Care, understanding the barriers to timely diagnosis and identifying solutions. It's lovely to see you all. Well, it isn't because I can't see you, but I'm sure you are looking lovely in your homes and offices across the UK. But thank you for coming to this meeting, and I'm very sorry that we're slightly delayed getting started this afternoon due to just one or two last-minute technical hitches. But it's lovely to see you here to discuss what I think is a really important subject about the role of primary care in identifying and diagnosing axial SpA. And this has been touched on in previous meetings, that primary care is the key piece of the puzzle here in terms of achieving the overarching ambition of bringing down that 8.5-year delay to diagnosis of AS in the UK, which is a really long time period compared with other comparable countries. And it's often GPs that those with axial SpA will present to with those first symptoms of AS. So getting awareness of axial SpA amongst those people is important, but it's not always high at that level of awareness. And we're going to be hearing from our presenters in this meeting this afternoon that there are real challenges to avoiding a scenario where a disease is misdiagnosed as for example, a non-inflammatory form of back pain. It is true to say that there's big pressures facing the primary care workforce at the moment, and that any conversation we have about axial SpA, obviously that has to be taken into context. But it is important, I believe, that we work to find the solutions to make the best use of the available resources to make progress in what I think is a critical area. And achieving this is timely as the NHS continues to evolve. New models of commissioning services across England are being established, and that's something we're also going to hear more about in our presentations this afternoon. So I'm very grateful that we're going to have 4 expert speakers this evening to talk about the wider aspects of primary care, axial SpA, and wider NHS policy. Following these presentations, there's also going to be a group discussion. So with that in mind, can I just make you aware that we've got 2 functions, I think, on this Zoom. We've got a Q&A function and a chat function. So if you've got a question for the Q&A session afterwards, please do put it in the Q&A function. And if you just want to have a general chat amongst yourselves, please do use the chat function that's there on your screen as well. So we'll use those to share your thoughts and questions on the presentations that we've got, and we'll come back to those in the second half of the meeting this afternoon. Just to flag up as well that this meeting is being recorded, so please do be on your best behaviour this afternoon, because we're going to make this available to on the NAS website to those who unfortunately aren't able to join us this afternoon. If I could give a brief update on some of the work, well, very recent work of the APPG. So before we come to our speakers, I just wanted to say that Dale Webb and I had a meeting this morning with Ed Arger, the Health Minister, to talk about hydrotherapy services. And that meeting was arranged following our previous APPG meeting, the theme of which was hydrotherapy. That provoked a question in the House, which I asked, and Ed Arger agreed to a meeting and gave us an opportunity as an APPG, as NAS, to really highlight to ministers and officials at the Department of Health the importance of putting more support in place to keep those pools open and to make sure that they are reopened post-COVID, and they really need to get it protected. We're awaiting a formal response from the Department of Health to that meeting, which was only this morning. I don't want to preempt that, but I would say that the body language and the words at that meeting appear to be positive. So that will hopefully be good news, but we'll see. But without further delay, I'm delighted to welcome our first speaker in today's presentation, and that is Dr. Louiseburton. Dr. Warburton is a GP with a special interest in rheumatology, and she's based in Shropshire, and she'll be providing a first-hand perspective on the role of primary care in the management of axial SpA. Louise.
Good afternoon. My name is Louise Warburton. I'm a GP with a special interest in rheumatology and an Associate Medical Director working for the Shropshire Community NHS Trust in Telford. I'm here today to talk to you about the challenges within primary care for GPs and FCPs working in primary care networks trying to diagnose spondyloarthritis. So we know that approximately 20% of all GP consultations are about musculoskeletal conditions, and they may be very varied in presentation. And some research from Kiel from 2019 showed that people presenting with symptoms of inflammatory arthritis are extremely hard to diagnose because the symptoms associated with inflammatory arthritis are common in the primary care population. So patients presenting with joint pain, joint swelling, a relatively high number of those presenting. So of 4,549 adults responding to a survey, about 52% of these consulted for an MSK problem, and for persistent, on at least half of the days of the month, inflammatory symptoms were common even amongst non-MSK consulters, with 42% reporting joint pain, 36% reporting joint stiffness, and 18% reporting joint swelling. And this is in comparison to 62% reporting joint pain, 50% stiffness, and 24% swelling amongst MSK consultants. So that's comparing non-MSK consultants with MSK consultants. And you can see that surprisingly, there isn't a huge amount of difference between the two groups. And so although symptoms such as persistent joint pain, swelling and stiffness are predictive of inflammatory arthritis, lots of people consulting with primary care complain of these types of symptoms. And this makes it even harder for the GP or first contact physio in a non-specialist setting to know what exactly to look out for and who to refer on to secondary care. And we all have heard a lot in the news recently about the pressures on general practice. So this paper was written in 2016 before the COVID problems. And we can see that GP workload has grown hugely, both in volume and complexity. So when I started as a GP 30 years ago, there were much more simple problems to deal with. People often just had one comorbidity. They wouldn't present with complex long-term conditions needing input from various members of the MDT. And the knowledge base for a GP has increased hugely. So the amount of information that one has to keep circling in one's head to try and manage people like this is just enormous. And it's so the increase in contacts, there's been a 15% increase in contacts, 13% increase in face-to-face contacts until COVID, and a 63% increase in telephone contacts. And this is in also a lot on a background of reducing GP numbers, so that the number of total GPs I think fell by 333 last year. We're not managing to fill that gap in provision. But here's just a sample of the GP curriculum that we're supposed to know everything about to pass the membership of the Royal College of GPs exam, and also to have at our fingertips so that we are ready for anyone coming through the door with any problem. So we get a 10 or a 15-minute consultation, and the range of subjects that we're supposed to have at our fingertips is enormous. And that's why it's hard to keep up one's practice as a GP if you're not doing 2 or 3 sessions minimum per week, because you just can't keep up to date with everything. So the challenges, therefore, for the average GP or FCP is to find that one case of axial spondyloarthritis, which might be presenting amongst everything else over the course of 12 months. So on average, an average GP with a list size of 2,000 would only see one new case of axial spondyloarthritis every 12 months or so. The number of people with back pain coming in through the door, much higher. So maybe one or two every surgery. So even for people who are knowledgeable about inflammatory back pain, who know about axial spondyloarthritis and who are looking for these cases, it's not very common and it's easy to miss them. So we need to really improve awareness in primary care amongst GPs, FCPs and those other clinicians with additional roles in primary care networks. Another misconception is that axial spondyloarthritis doesn't occur in women. I actually had a conversation with someone yesterday, a clinician, who I was describing a patient to, and they said, well, can it occur in women? And I was quite surprised, really, because 50% of cases do occur in women. And I know this is happening in many places, but we need a fast track assessment service for people with symptoms of axial spondyloarthritis. So ideally an interface clinic with access to fast and appropriate MRI scanning, because just straightforward normal MRI protocols won't pick up the features of spondyloarthritis. So that means GPs have to have a low threshold of suspicion and refer promptly onto rheumatology. Many people will have other conditions such as fibromyalgia. We also need services to manage these people, so we're not forgetting about them, and we need to have adequate care for people as well. So in Shropshire, we've been lucky to have an integrated Shropshire MSK service since 2016. We're working together with our local acute trusts, and we have a single point of referral, which means that all MSK referrals come through one point electronically and are triaged by a team of physios and extended scope physios and GPs. So all the rheumatology type referrals are triaged by myself and the other more experienced members of the team. And hopefully we have a low index of suspicion and refer them on to rheumatology promptly. We now have an integrated care system, and this is a map of all the MSK services which are on offer within Shropshire. So it looks very complicated because it is, but I think the learning point here is that a single point of referral works really well, and have a trained team of clinicians triaging who can have regular meetings to discuss cases and to work closely with consultant rheumatologists to make sure that we aren't missing anybody with axial spondyloarthritis. So it is a difficult condition to diagnose. I've diagnosed a lot of people who frankly didn't have typical symptoms, but I just have such a high index of suspicion. I requested the MRI and found out that there were inflammatory changes. So it's a difficult disease to diagnose, but we have to have a low index of suspicion. That's the end of my talk. Are there any questions?
Okay, thank you, Louise. And yes, if you've got questions on that, please do add them to the Q&A chat function, and we'll come to those during the Q&A part in the second part of our meeting, which will follow our presentations. But what we will now do is go on to the second of our presentations, which is from Dr. Denny Wallace. And Dr. Wallace is a consultant rheumatologist from University Hospital Southampton NHS Trust, who will be providing an overview of the area from her perspective of working in secondary care. Denny.
Thank you very much for the invitation to present at the APPG for Axial SpA. My name's Denny Wallace. I'm a consultant rheumatologist working in University Hospital Southampton, and I have a specialist interest in axial spondyloarthritis. I run the Axial SpA service here in Southampton, along with my colleague Jackie Tompkins, specialist physiotherapist. The problem will already have been highlighted by the other speakers in this meeting, and you'll be well aware that recognition of Axial SpA symptoms in primary care is a huge challenge. We know that during the course of the year, quite a significant percentage of the population will see their GP, specifically about back pain. For many of these patients, it's very hard for general practitioners to pick out the patients who have really inflammatory symptoms who require onward referral to rheumatology. About 30% of GP consultations are regarding musculoskeletal health. And we know that despite that, rheumatology teaching is a very small part of medical education in UK medical schools. And I've put rightly in brackets with a question mark there, because I know there's a huge amount of pressure on medical schools and their curricula to cover all the topics, and each clinician is fighting for their own area to be included with a higher priority. What have we done to look at rheumatology training for GPs and for medical students? Well, in 1992, a group of rheumatologists worked together to write guidelines on undergraduate curricula in the UK for medical schools. And it was hoped that by creating these guidelines, it would encourage the inclusion of basic rheumatological competencies within the core curricula for all medical undergraduates. And within that, it was documented that the clinical presentation and natural history of common rheumatic syndromes and major rheumatic diseases should be included, as well as how to come up with a differential diagnosis for the common manifestations, which would include back pain. About 10 years later, so in 2000, published in the Rheumatology Journal, a group of researchers looked at what changes had happened in the previous 10 years, so following on from the first publication, as I mentioned, particularly looking at current practices and changes between 1990 and 2000. And in their conclusions, they found that in 5 medical schools, up to half the students might not actually receive any clinical rheumatology teaching. The time allocated to rheumatology teaching had fallen from a median of about 4 weeks during the whole undergraduate curriculum to just over 2 weeks. And actually that in some medical schools, rheumatology may be seen as an elective topic, so something which can be selected if a student has a particular interest, rather than being a core component. What do European organisations have to say about rheumatology training for medical undergraduates? Well, EULAR, the European League Against Rheumatism, in 1999 proposed a curriculum for use in European medical schools. And they do specifically focus on back pain, mechanical and inflammatory back pain, as well as the red flag type presentations of back pain. And that includes ankylosing spondylitis or axial SpA. What about GP training? And I know we have a presenter here today who is more qualified to talk about GP training, but just from the secondary care perspective, I thought I'd have a brief look at what the GP curriculum includes. And I found that the curriculum is approaching 300 pages, but on page 225, there is specific reference to being able to identify patients with spondyloarthritis, such as psoriatic arthropathy or axial spondyloarthritis. What about the secondary care perspective? Well, here in Southampton, I do see a lot of back pain referrals, and I would say that on the whole, those referrals are entirely appropriate. The GPs in our region have picked out and sent patients who have inflammatory type back pain or extra articular manifestations such as psoriasis or uveitis or inflammatory bowel disease. I don't feel that we're being sent a large number of patients with mechanical back symptoms, which is good, but that leaves the question of which patients are not being referred. Those are the patients that we don't know about. I think there probably is some misunderstanding just based on informal conversations with primary care colleagues or some patients who are primary care physicians about the utility of blood tests and x-rays such as HLA-B27 and whether a negative result, how a negative result is interpreted in primary care. So there's probably a role for some further education from us to our primary care colleagues about interpreting those tests. Looking at the Southampton experience in a little more detail, we've taken part in NAS's Aspiring to Excellence programme, which I'm sure all of you know about. with one of our goals in that project being to improve the time from presentation of AS symptoms in primary care to the time it takes for a rheumatology referral to be made. And we started by looking at our current performance, particularly exploring the organisation of care at UHS, which at times can seem impenetrable, I must say, but looking at the referral pathways and systems. And to establish our current performance, we performed an audit looking at around 70 patients who had been diagnosed with Axial SpA in the last 3 years. And we found that in our clinic, the median time from symptoms developing to being seen in the rheumatology clinic was 1 to 2 years, which actually in the context of things doesn't seem too delayed, but there was a significantly wider range of 0 to 14 years. Our clinical specialist physiotherapist, Jackie Tompkins, also conducted 5 telephone interviews with those patients identified in the audit who did have a very long delay to coming to the clinic, just to understand the context of their delay. We asked them some questions. Why do they think it took a long time to get diagnosed, with further prompt questions if required? And these are the sorts of themes that came out in their answers. Mechanical back pain is so common. If your range of movement is normal, then you don't have it. You don't look like someone who has AS, or because you're younger or a female, perhaps AS wasn't suspected. We also identified some feelings that the pain wasn't necessarily fully appreciated when they first presented. No one believed me, and having felt a bit embarrassed to try and ask specifically whether I might have AS. To explore the organisation of care at our hospital in a bit more detail, we met with our e-referral projects manager just to understand what GPs see when they're trying to make a referral, because the GP referral system isn't always clear to the secondary care team. We found that we didn't have a specific inflammatory back pain pathway, and that the criteria for which patients should be in which clinic weren't necessarily identified correctly or in an up-to-date way. We had some suggested investigations for conditions like rheumatoid arthritis, but nothing specific for inflammatory back pain. But it wasn't really clear to us whether the referring GP actually would read those booking criteria or whether the booking criteria were inaccessible. We've designed a survey to ask local GPs if they use the e-referral system, and if they do, whether they look at the booking criteria and about their confidence in diagnosing Axial SpA. The aim really was to put some educational material into the e-referral system and to help them identify patients more easily. Because that was during the time of pandemic, that's all been postponed for the moment, but we hope to have some results soon. And we redesigned our e-referral pathway with a new service linking inflammatory back pain referrals directly to my clinic, as well as adding some suggestions about first-line primary care investigations, along with advice for how to interpret those. So overall, from what I've thought about opportunities for improvement, well, I think we do need a continued drive to engage medical students with rheumatology teaching. It may need to be more opportunistic than specifically timetabled because of the pressures on the curriculum, but also to attract GP trainees into rheumatology placements and to provide rheumatology teaching as part of their protected learning time. We've tried to put educational content into the GP referral system so that people can't avoid it. They have to look at the booking criteria, the symptoms of inflammatory back pain, and the recommended investigations. Local GP champions for musculoskeletal health is one area which could be investigated, as well as close networks with hospital colleagues that we already have, for example, with gastroenterology, ophthalmology, and dermatology. I'm going to finish there, and we'd be very happy to take any questions later during the Q&A. Thank you.
Thanks, Denny, for that interesting presentation, and do keep your questions coming into the Q&A on that and everything else we're going to be discussing this afternoon, so that we can discuss them in the second half of the programme. But now we're going to go on to the third of our presentations, which is by Abigail Henderson, who leads the First Contact Practitioner Programme at the Chartered Society of Physiotherapy. Abigail.
Hello everyone, my name is Abby Henderson. I'm the Head of FCP Implementation here at the Chartered Society of Physiotherapy, and I'm here today to talk about the role of first contact physiotherapists in recognising axial spondyloarthritis. So thank you for the opportunity to speak about such an important issue. So just to start with, we'll just recap and review what the FCP model in primary care actually looks like. So this is really about patients being able to access and see the right professional at the right time from within the primary care team. So this is where FCPs bring their MSK expertise right to the start of the pathway. And the really important aspect is that they are seen the same way as they would see a GP. So that's often through just the practice receptionist or local triage processes. And that way they're often able to be seen the same day or the next day, which really helps to reduce delays. What the FCP will do is offer a really advanced MSK assessment, and the really critical thing about being able to recognise axial SpA lies in this really high level assessment, which is really focused on seeing and identifying those red flags or suspicious features that makes an FCP think, okay, there's something else going on here. We really need to refer this patient on for specialist advice or specialist intervention. But of course, they are there as well to provide that diagnosis if they can. So they are primarily diagnostic clinicians and provide that first line intervention that they think is most appropriate. So often this is around self-management, physical activity, social prescribing. And of course, many FCPs are also able to prescribe or give injection therapy as well. So how does that model of care really fit into this recognition of axial SpA? And what we've got here is the principles of FCP. And I think you can see how those things, that list there of those principles, how the interplay between all of them can really support and be facilitators for FCPs to be able to recognise this condition, which obviously is so important. This illustrates what the FCPs have to offer if they work in this way, and we'll just talk about a couple of those elements in a little bit more detail here. So the level of practice that FCPs operate at is a real facilitator for this. So they're really experienced MSK clinicians who move into primary care, and they should all be working at a really high level of practice. They've got that advanced clinical reasoning and that ability to manage that complexity that comes with seeing an undifferentiated caseload. And this is really reflected in the fact that FCPs are banded at band 7 and band 8A. But it's been really very much supported by the recent publication from Health Education England, which really lists the knowledge, skills and attributes that are needed to have this role in primary care, and that's through that roadmap to practice, which hopefully many of you will be familiar with. And there's real focus in here about again about that ability to recognise those conditions that really do or suspect those conditions that really do need that greater level of investigation. But of course, FCPs as well bring with them a wealth of expertise of MSK and wider, related areas of practice. And many of them still retain that with having a portfolio role, so spending some time in primary care, but also spending other time either in core physio services, rheumatology, orthopaedics, triage services. There's a real range of expertise there. But a crucial part of the FCPs being able to support patients to get a diagnosis of axial SpA and recognise those warning signs is to have that support and be really integrated, both within local pathways, but also within that primary care team. So understanding how the pathways operate, so knowing what is best, what's recommended for that local area, for their rheumatology pathway, what investigations should be done, what bloods should be done or shouldn't be done because you may have a different pathway, access to that specialist advice, maybe through advice and guidance, or just through an open access to the rheumatology teams is a really important part and facilitator here. And without that knowledge and relationship, the impact of FCP is likely to be less. But also, if the FCP is truly embedded into that primary care team, they will share that knowledge and share that expertise, and contributing through training, multi-professional supervision, having that open access to GPs, and that supports the primary care team as a whole to upskill their knowledge and expertise to detect this condition. And I think that's really illustrated here by a couple of case studies from an FCP. So you can see here, firstly, a 23-year-old female complaining of that back pain with those warning signs of early morning stiffness, being worse with rest. Saw a GP who gave advice, and then independently that patient decided to try some other interventions such as physiotherapy and osteopathy. But it was when they went back that didn't resolve, and it's when she went back to the FCP who just recognised, who had that thought, you know, this pattern just doesn't fit. This just does not fit right. It doesn't match with anything that I've seen before. So therefore, recognised that symptom pattern and referred onto the local rheumatology pathway, which meant a length of diagnosis of 18 months, which obviously is much quicker than many unfortunately experience. Conversely, we have here a 31-year-old man who attended with a 10-year history of low back pain, who had really struggled over this time with lots of GP attendance, escalating use of painkillers, was depressed, was out of work. And it was the FCP who uncovered a wider familial history of axial SpA and put this patient on the right track to getting a diagnosis. But critically as well, obviously we can see the impact to the individual patient this would have had, but critically in both of these cases, the FCP was truly embedded in that primary care team and had those relationships to be able to go back to those who'd previously been involved with their care, just to highlight the learning that could be gained from this experience. So if we go back to looking again at the FCP model and looking at it from an axial SpA context, it's just to summarise really that yes, this is a first contact model, but that doesn't mean it is only for those with acute conditions. FCPs are really well supported to manage those with chronic problems or recurring problems and to be able to support them through those. They do manage an undifferentiated caseload. They manage that uncertainty, and with the expertise they bring, they are therefore able to recognise these inflammatory conditions. They have advanced clinical reasoning, and this makes them, as physiotherapists are, autonomous practitioners, but they are autonomous within the context of being part of that primary care multidisciplinary team. Crucially as well, they are bringing expertise to the start of the pathway, but it's recognising that this expertise is part of that wider pathway. But of course, there are similar barriers to FCPs that as GPs face in terms of diagnosing axial SpA, and knowledge and awareness of it, as you know, can be quite limited, and it is common to the different professions. But I think what's really key is that as we develop more and widen our MDTs working in primary care more, it's about being really switched on to asking the right questions at the right time, and that's really crucial to improving delays in diagnosis. And I think it's fair to say that FCPs can play a really key role in spearheading these teams. So I hope that's been a useful quick run through, and do check out our CSP resources, which are open access to anyone with an interest in FCP, and thank you for listening.
Thank you, Abigail, for that presentation. Do keep the questions coming in to the Q&A. But first of all, before we get to the Q&A, we are going to go to our final presenter, Chris Mercer. Chris is the clinical lead for the Primary Care and Community Work Stream for NHS England's National Best MSK Health Programme. Over to you, Chris.
Thanks very much, Tom, and apologies everyone for not having this recorded. We tried, but you've got me live instead. So thanks for the invitation. I'm going to give a brief overview on the Best MSK Health Programme, how the programme sits, how the primary and community care programme sits, and then some detail on how it might affect people with Axial SpA. Next slide, please. So that's me. Those are my contact details. I'm very happy to be contacted after. Next slide, please. So the Best MSK Health Programme is an opportunity. It's an opportunity for MSK overall to build on opportunities that have arisen and developments that have happened during COVID. The whole system has responded magnificently to COVID, and we've developed new ways of working, new integrated ways of working. So there's an opportunity for us to build on those. Next slide, please. So it's quite a complex picture. And this is a little bit busy, but what it really says is and what this does is speak to what the Best MSK Health programme is about, and that's about integrating care. So we've got community care, primary care, secondary care, tertiary care, all wrapped around and linked in together. It's absolutely vital if we're going to deliver good and best MSK Health that we deliver integrated care across all settings. And we've heard from previous speakers around the primary and secondary care and the role of FCP. Well, they're all encircled in these opportunities. And the Best MSK Health program is part of a national pathway improvement program. It's one of the 3 priorities alongside ophthalmology and cardiology. So this is our opportunity in MSK Health. You know, the spotlight's on MSK Health, and we need to deliver in terms of this being a great opportunity for us. Next slide, please. So this slide just shows the work streams of the Best MSK Health programme. They're divided up into some clinical work streams and some supporting work streams. So the supporting work streams around data, personalised care, and the clinical work streams around spinal, around orthopaedics, but also, as you see, around rheumatology. So there's a dedicated work stream for rheumatology. I think the Lesley K is on the call here. So Lesley and Peter Lanyon lead that fantastically. The work stream that I lead is the primary and community work stream, which I think reaches into all of these different programmes and all the different work streams and helps to pull them together, because primary and community care sit at the front end and the back end of most care. We know that 75% of care for people with MSK conditions happens in primary and community and not in the elective care setting. Next slide, please. So here are the work streams, excuse me, the focus of the work streams from the primary and community work stream. So we have specific work around pathways. So there are pathways project looking at high volume, low complexity conditions. So we're looking at osteoarthritis of the hip and knee, shoulder conditions and spinal conditions, and included in the spinal conditions is axial spondyloarthritis. There are significant issues around workforce. We've heard that from the other speakers today. So the FCP onward development and discussions comes under this work stream. Access to specialist advice and guidance. I'll talk a bit about some of the documents that are coming out later. Again, this is really important in terms of getting diagnosis early, getting the right people referred at the right time. So we're looking to support the system with these documents. And also we're looking to improve data. Data in primary and community care for MSK conditions is, let's say, not as good as it could be. And I think that's one of our big challenges is to help identify these patients and help identify their journey and help us to manage and plan services in the future. Next slide, please. So the next couple of slides, they're quite busy and they're not intended for you to read the detail, but these are examples of the pathways that we're developing in the primary and community work stream. So this part, there's a pathway for clinicians that is clinician facing that describes what we would expect to happen at each encounter, at each step of a patient's journey through the system. And you can see at the end, the arrows at the end loop this patient back into primary and community care. So we're looking at capturing front end and back end of a patient's care. Next slide, please. And similarly, we've designed these guidance documents for commissioners, so commissioners of services to identify transformation opportunities, so that then we can help not just the patient journey, not just the clinicians, but we can help the system to improve the whole system. So we've identified here evidence-based resources and opportunities for transformation within the system. And alongside these two pathways, there will be a patient-facing pathway of what people can expect during primary and community care, but also a resource, a pathway guide for digital services and digitally enabled services that will help direct people towards digital resources to support their care. Next slide, please. So this is these are some of the priorities around primary and community care we've identified, and these are around pathways. Each of the work streams has key high impact changes that we're looking to develop. Next slide, please. Obviously, this can't be done on our own. This is Best MSK Health Collaborative, and these are just a few of the people that we've collaborated with. This covers NHSEI organisations, but also other arm's length bodies, lived experience groups, patient groups and charities. So we're working and trying to work across all the sectors to try and integrate and pull all the good work that's been done out there, trying to pull that together. Next slide, please. So more specifically for rheumatology, I know Lesley could talk much better to this, but these are the specialty recommendations for rheumatology, and you can see right in the middle there is standardised and streamlined pathways for early identification of inflammatory arthritis and spondyloarthritis. So axial spondyloarthropathy is front and centre of the Best MSK work stream, and it's certainly high on the agenda of the rheumatology work stream. Next slide, please. Grab the next slide, please. Thank you. And this is writ large in the plans for development of the pathways. And next slide, please. The next two slides are taken from the draft pathways for inflammatory arthritis that are out for consultation at the moment. And again, these are quite small, but really the point is here that the bits that I've circled are specifically related to axial spondyloarthritis. So again, these pathways are divided into what should happen at each stage to the patient, what investigation should happen, how certain diseases should be identified, and we've got axial spondyloarthropathy in here. We've also got it in the next slide in terms of who should be involved in the care, excuse me, and what intervention should take place specifically for axial spondyloarthritis at each stage. So it's all very clear. So these pathways, these draft pathways, are available on the Futures NHS website, and I'm sure Lesley and Peter will be very happy to take any comments. But I guess it's just really to reassure everybody on the call that axial spondyloarthritis is a clear and important part of the Best MSK Health programme. Next slide, please. So in terms of next steps for the Best MSK Health programme, amongst other things, and I think the things that will be useful will be some urgent and emergency guidance updates around early identification of inflammatory disease, the development of a musculoskeletal data set for primary and community care that will help to feed into community model hospital systems, so that will enable clinicians to benchmark their services and monitor the services going forward. I've talked about the pathways where axial spondyloarthritis is specifically mentioned, and this will help to standardise provision for patients with musculoskeletal problems, and specifically axial spondyloarthritis. Specialist advice and guidance documents are due to come out, and this will help the system to identify the right patients, to get the right patient to the right clinician at the right time. And the PIFU guidance is around patient-initiated follow-up, and this relates to ongoing management of people with long-term conditions. And again, I think that's pertinent to people with axial spondyloarthritis. So I think just to say thank you for giving me the opportunity to briefly share where we're at with Best MSK Health, and look forward to your questions. Thanks very much.
Chris, thank you for presenting that to us. Thank you very much. And that brings us to the end of the presentation side of this evening's meeting, and we're going to now move on to the discussion side. of the meeting with our questions and answers, which is going to be, if I get my words out right, will be facilitated by our CEO of NAS, Dale Webb. Dale.
Many thanks, Tom, to you for chairing, and also to our speakers for a really fascinating discussion. And as Tom said in his opening remarks, primary care is a critical part of the puzzle and of the solution in securing early diagnosis. And I want to say that in all of that, what we are absolutely not seeking to do here is to demonize our colleagues in primary care. And I've just noticed reading some of the chat, some of the comments about that, the current context of abuse in primary care that our colleagues are experiencing is completely unacceptable, and that COVID has placed huge challenges on all of our NHS staff, and we absolutely applaud the Herculean work that all of them have been doing for the last 18 months and continue to do in this challenging period. I'd like to invite our speakers back onto the floor, please, if our technical colleagues can arrange for that. And let's begin with a conversation about visibility of Axial SpA within primary care. Thank you. So we heard in Louise's presentation the fact that the average GP will see few Axial SpA patients on average. And yet at the same time, we know that AS isn't a rare condition. 1 in 200 adults we estimate live with the condition. So what do we think we can do to raise the visibility of Axial SpA within primary care and raise make Axial SpA higher within the clinical reasoning of an average GP? Who would like to come in and speak about that?
Shall I say something as a GP? I think we need some reminders, really, and I know that NAS are working with Raj Singh Gupta on a pop-up that will appear on the computer screen when a patient has certain comorbidities, such as ulcerative colitis, and that acts as a reminder, really, that maybe here we are dealing with a patient who's presenting with early signs of Axial SpA, because you just can't keep all that information in your head all the time. And another thing is to have some enthusiastic GP champions, as Denny said. So nothing comes across better than somebody who wants to talk about Axial SpA who's enthusiastic about it, and people remember that. So those would be my two bits of advice, really.
Thank you, Louise. Any other comments from panelists?
I think the other thing is just, thanks, Dave. Just to think about, obviously, the big and traditional primary care workforce is GPs, but I think, I'm sure Abby would agree, the development of FCP roles. I think in physiotherapy there is a growing understanding and a good understanding of presentation of axial spondyloarthritis, and I think that that they will play an important role in working with GP colleagues and other primary care colleagues to help identify and manage patients, and have the skills to be able to do that early on in the patient's pathway. So, and I think there are some rheumatology specific clinical interest groups that have developed in physiotherapy over the last couple of years, and so again I think it's higher on the agenda. So I think there's a broadening workforce to help support that.
Thank you. And Abby, in your presentation, you said that FCPs have a more advanced clinical reasoning of Axial SpA. How well understood is that, do you think, within the broader primary care community, and how well embedded do you feel FCPs are now into the new primary care landscape?
Yeah, absolutely. So, so I think it is that level of practice that FCPs are working at that really bring that, and that's building, as I said in my presentation, on the experience and expertise that they have. But absolutely, part of their role is about bringing that into the wider primary care team. And I think the role was relatively new and is still evolving. And places are in different regions, even locally within regions, are at different places with FCP. But the important thing is the recognition of how important it is for those FCPs to be embedded and integrated, to be able to do all the things that I've spoke about in the presentation and Chris has alluded to. And I think the other thing also is about being given time, which I know is incredibly precious in primary care, but it's time well invested to support FCPs and colleagues to continue their development, their learning, that to spend the time doing that integration piece, which will upskill, which will support primary care as a whole.
Thank you. I can see we've got Dr. Roshan Gupta, who's also joined us on stage. Rosh, thanks so much. Louise talked about some of the work which you're leading in terms of GP pop-up tools to help GPs. Tell us a bit more about that, please.
Yeah, thanks, Dale. And it's been really interesting listening to everyone's presentations this evening. Actually gives me a bit of hope that we're on the right track, which is really nice. And particularly, I think, Lesley, with your pathways, that really looks super work that Chris presented. So some of the things we've been doing, Dale, I mean, I started this a few years ago with the SpA tool, in fact, which was based on some research that Martin Rudverlight and Ernst Felkeller did, which was bringing common features of axial spondyloarthritis to a digital interface with clinicians could tick boxes and get a probability of AxSpA, and patients could then be referred on to secondary care. And the next bit was then thinking about whether we could integrate something like this into GP services. And with a company called Primus and support from yourselves, Dale, in NAS, we developed the Popup tool. So essentially, when the GP's typing in back pain, the system in the background would check things like the age of the patient, whether there are other features like uveitis, psoriasis, Crohn's disease, other things involved, and if they've come back more than once, and then put this pop-up for the GP. And I think, to my understanding, and Louise will correct me if I'm wrong, but I think anyone using GP EMIS system, and that can be an FCP or a pharmacist, would be able to access the same sort of pop-up tool, which I think could and should help. Now, rightly, this has not been validated for use, so we've got to be a little bit careful, and there are studies being planned where the tool will be validated and checked. But at this stage, it's something that's going to be available for a lot of GPs to use. And my final piece I'm just going to say is I've been also involved with a really exciting piece of work with the CPRD, which is going to be presented at the ACR coming up. And what was really interesting about the CPRD work was actually around 850 different parameters was searched with information that GPs collect away from things like B27 uveitis, and out of those 89 features then were used to diagnose, to identify patients with axial spondyloarthritis to around 90% sensitivity and specificity. What's really interesting about this, Dale, is things like the duration of the GP appointment, the number of times the patient came to collect prescriptions, the number of referrals the patients had, a wide range of features. So I think all of these things are taking us in the right direction, but a lot of work has to be done to validate these tools.
Many thanks, Raj, and thanks to you for really spearheading this development, which I think holds huge potential actually in identifying patients. I'm seeing some comments on the chat from some of the people who have axial SpA. I'd like to bring onto the stage, please, Francis Reed, who's posed a couple of questions for us. If we can bring Francis up, that would be wonderful.
Where's my...
Brilliant. Francis, very good to see you. Many thanks. Do you want to pose the questions that you put in the Q&A?
Yes, and it sort of follows on a bit from what Raj was almost saying, which is a tool for GPs. And my question was, you know, I've had to have a hip replacement. When I very first went to my GP surgery, and this was quite a few years ago, I wasn't even allowed to go and talk to my GP until I'd completed a hip score sheet. So I literally arrived at the surgery with my hip score sheet that the GP then looked at. And this, I think, in a similar way with a validated tool, like Raj is saying, would actually help some of the patients get forward, because you don't know as a patient what the key factors are that you're meant to be looking for. So it would, you can't sort of prompt the GP if they don't ask you. So, you know, psoriasis, yes, I had psoriasis. Did I have other pains? Yes. You know, all these sort of questions. What type of pain is it? And given that back pain is, you know, one of the most common appointments at a GP surgery, it makes sense to focus on helping the GPs in all ways possible to narrow down as quickly as possible what might be going on.
Thank you, Francis. Any comments from the panel?
It's all about time, isn't it? I think I have more success in diagnosis because I have a 30-minute appointment in my specialist clinic. And that's loads of time to chat to patients and find out all these very soft signs that you're describing, Francis, such as tiredness, lethargy, not being able to do as many things as you used to. It's just so much easier, and we're under so much pressure in primary care at the moment. We just need more resources, more FCPs, more GPs, more time, please. Tom Randall, I'm asking you as a member of the government, please. And then we'd have time and the emotional capacity to ask the right questions.
Thank you, Louise. I can see some comments in the chat relating to the Popup tool. Perhaps we can answer those separately, Raj, rather than going through them right now, but there are a couple of things there. Francis, thank you for sharing your perspective on all of that. Denny, in your presentation, you talked about relationships between secondary care and primary care colleagues. What's your sense about how, overall, how strong those relationships are, and what helps and what hinders strong relationships, do you think, in that context?
In my experience, the relationships are very good. I know that there's, very much trying to avoid criticism of any one group in a really difficult time, and I don't think there's any criticism due to either group. I know it's difficult for patients to get access to secondary care, and the things that help those relationships, I think, are knowing the local GP groups and first contact practitioners, having opportunities to go and talk, whether that's virtually or face to face. And Louise may be able to comment on this more, but also having ready access via the system called advice and guidance, where a patient may not necessarily need referral, but the GP might want to get some informal advice about whether referral is indicated. That works very well for us, relatively quick to respond to those queries. And also you can send back some education about what the most useful tests are for that sort of circumstance. So the meeting people face to face, I think, is really important.
Thank you, Denny. Any comments from other colleagues about this?
Actually, I'd be interested in asking Louise on her perspective on that question. What do you find most useful to have from rheumatology consultants?
It's accessibility, really, and a friendly relationship, so that I know we all have advice and guidance, but we've stopped having clinical meetings, haven't we? We used to have really nice meetings in the hospital where we would all get together, a load of GPs and a consultant, and you got to know them really well, and then you could pick up the phone and just ask questions, but that relationship sadly seems to have disappeared.
I agree. I think that those are events which used to happen probably in the days before I became a consultant, but actually since becoming a consultant, often they were evening events, and I think yes, the pressures on both sides are that actually by that time you're either still at work or don't quite have the enthusiasm that perhaps you used to have. But now that we can connect digitally, that could be overcome, I think.
Yes, and that certainly helps.
Thank you. And I see, Chris, your hand is up. Do you want to address the same point?
Yeah, just briefly. It was just really to say I don't agree entirely with what people have said. I just think there's something also about making sure that for secondary care colleagues aren't inundated with non-inflammatory back pain, and I think non-inflammatory back pain is a massive issue, but it's an issue that needs to be dealt with in primary and community care. It's not a secondary care problem, but it's filling up secondary care clinics. So actually that means that the specialists who can help with the inflammatory arthritis sometimes struggle just with the actual workload. So some of the pathways, some of the when to refer documents, those kind of system supporting documents should hopefully help with that. But I think that's an issue that runs alongside what we're talking about.
Thank you, Chris. I wanted just to touch on your presentation. So, I mean, it's wonderful that I think for the first time, MSK Health is on the national planning agenda, planning priority. And the development of the best MSK programme, I think, is welcomed by all of us in terms of the intellectual coherence it's bringing to numerous things coming together, including the GIRFT work, the leadership of Andy, yourselves and others, and there's a growing momentum here. But set in the context of the most awful challenges for the system, I guess I'm asking you really, what optimism do you have about the role of best MSK, and do you feel it's getting traction within the regions at the moment?
I think it does. If I didn't have optimism, I wouldn't keep doing it, because actually I've been doing MSK work for a long time, and actually, this is probably the best opportunity. This is where the spotlight's been shone on MSK. So I'd be a fool to walk away from it now. And I think, awful though COVID was, actually what it took us back to was lots of MDT working and lots of virtual consultation, and actually facilitated some of those cross-sector discussions. And I think people have seen the benefit of that. And I think with the support of digital innovations and digital resources, we're able to communicate much more freely and much more openly, if you like. So I think that's supportive of the integrated approach that we want to take with Best MSK Health. In terms of the regional engagement, we're very engaged with regions. There are regional MSK Best Health representatives. The regions have had a toolkit to kind of audit toolkit to see, to kind of self-assess where they're at. So we're very engaged with regions in terms of moving forward to help deliver the programme. It can't come from a national perspective, it will never land. So it has to be driven by the regions, but also it has to be driven by clinicians from the bottom up. So we're trying to engage, so top down, bottom up as well, Dale.
Thank you, Chris. I know we have National Technical Director Andy Bennett here. Can we bring Andy onto the stage too, please? There he is. Andy, hi, welcome. Great to see you as always. Listening to the conversation so far, what are your thoughts and reflections?
I don't have a great deal more to add now than what my colleagues working on the Best MSK programme have said. Essentially, we've got a significant challenge across MSK. We have a significant challenge in the AS space that's been complicated by the experiences we've had over the last 18 months. But we have an opportunity through the Best MSK Health work to take the sort of ethos of integration, collaboration and co-production, and we built in response to the pandemic forward to try and restore services in a better way. And so meeting targets such as reducing the time to diagnosis for AS is key to that and a key ambition. And I think, colleagues such as Chris, who are doing fantastic work, and I know my rheumatology colleagues involved in the programme, Lesley is on this call and has been commenting, are really driving this forward, not only in the rheumatology space, but the primary community care space. And I think the exciting thing about it is how that's being done collaboratively. And Chris talked about the ambition to optimise rheumatology capacity by ensuring non-inflammatory conditions are best managed in the community. And the wonderful thing about what we're developing is that that direction is being developed collaboratively between experts and stakeholders in primary community care and rheumatologists rather in silos. So I think, lots of great points have been made and lots of great opportunities. What we're trying to do is provide that vehicle to take them forward and adapt and adopt them locally.
Brilliant. Thank you, Andy. And now we're joined also by Lesley, who is leading the rheumatology work stream in Best MSK and who co-leads the GIRF rheumatology work. Good evening, Lesley. Great to see you too. What are your reflections listening to the conversation?
I think what a great range of things people have talked about, and I think we've identified the pressures at every point. So I would, of course, promote the GIRF report to everybody. It's available now on rheumatology, and it really does talk about the pressure on rheumatology services, how we might have to make the best of every appointment we've got. But there are two things that I think people can do that would really help to promote the Best MSK Health work, which is, from our perspective, based on some of the GIRF work. So I think one is to look at the pathways. They're on the NHS Futures site, and we'd really appreciate comment on those, but also promotion of them to anybody locally who you think would be useful in that. And, dare I say, particularly commissioners, because I think they need to understand what they should be commissioning in a rheumatology service, what it should have. The second thing I think is to look at the local regional leads for MSK within the Best MSK Health and the recovery programme. Some are appointed, some are being appointed at the moment, and unless Andy knows any different, or Chris, I think so far they're nearly all orthopedic surgeons, and so we have to keep mentioning rheumatology in the context. And we've done a great job in promoting rheumatology in that. But you know, our orthopedic leads, if they are regional orthopedic leads, need to be painfully aware that they are also responsible for rheumatology as well as orthopedic waiting lists. So I think we've all got a job to do there where we can help them. So find out who it is. If they haven't been appointed yet, put yourself forward, get yourself appointed, and use all the lobbying power we've got for that, because I think, as Chris and Andy both said, this is a massive opportunity. We cannot afford to let this opportunity go.
Yeah, and absolutely, and I think that's a point very well made, Lesley. And I mentioned it earlier that I think that one of the good things about MSK is it's bringing together multiple things going on in the ether. And there's a question from Rebecca Paris asking about how is Best MSK working with HQIP, in particular the National Early Inflammatory Arthritis Audit. What kind of interface is there, do you know, between Best MSK and the NEA audit?
So I think it's a matter of public knowledge that the audit last phase of it came up for renewal recently. So we absolutely have the NEA audit for both peripheral rheumatoid arthritis and for Axial SpA front and center of what we do. It's about the only thing where we measure outcomes in rheumatology routinely. So we have absolutely supported, put all the pressure we can on to having that program recommissioned, retendered, refunded, and also particularly in GIRFT, I think, rather than Best MSK Health, when we visit every rheumatology department, we're discussing their local results. We're trying to understand the barriers for people getting patients into that. And we're lucky, we often have the chief exec or managers in the room, and they may perhaps not have understood the perspective of how important that audit is. So I think, again, it's integral to our program, and we've been pushing it as hard as we can.
Thank you, Lesley. And I see that part of Rebecca's comment is that she feels that the audit may have focused more on RA rather than Axial SpA, but I can report a really positive meeting that Rajshen Gupta, Carl Gaffney and I had with the leadership of the BSR team to look at the audit with regard to how we can better promote and ensure higher uptake among Axial SpA patients in the audit, and indeed make some modest changes to the audits tool too. So I sense, Rebecca, that we might be heading in a stronger position on that going forward. Okay, so I'm just looking through all the questions we have. Thank you for all of them. There's a question just going back to Best MSK pathways. Lesley, a question from Claire Jeffries asking whether the pathway will encourage rheumatology departments to accept referrals direct from HCPs and or advice and guidance. Could you speak to that, please?
Yeah, so there's two different issues really. So we are promoting advice and guidance led referrals, so that it changes the conversation for the GP and the patient, or the FCP and the patient, that I'm asking specialty advice about whether you need to be referred or what else I should be doing, so that referrals are being pushed towards, nudged towards advice and guidance, a conversation being the front end of any referral. The second thing is we have deliberately stayed neutral about setting and healthcare professionals. We've talked about competencies and the process of what needs to be done. So again, Chris has been very involved in most of these conversations, I think, as have a lot of others, but it needs to be an appropriately competent person, and I think we should not split hairs about what degree you got 30 years ago.
Thank you, Lesley. Anyone else want to come in on that point? Okay, one of the discussion points outside of here has been the question of where should the diagnostic test be undertaken within primary care and secondary care. I wonder whether anyone wants to speak to that particular point. Louise, do you want to
yeah, I put a question in because GPs where I work have direct access to MRI spine, and sometimes even whole spine MRIs, but not the inflammatory back pain protocol, with the stir images. And I just wondered if anyone has looked at pickup rates if GPs were given direct access to the correct type of MRI if the patient fulfilled the criteria for inflammatory back pain.
Good question.
I don't mind coming back in on that just a little bit. I mean, I don't think that's been looked at, Louise, and certainly in our area, our radiologists do not accept referrals from primary care for inflammatory spinal protocol MRIs. And partly I'm a little bit supportive of that, partly because I think the interpretation of MRIs is really difficult, even at the best of times, when they so-called say there are inflammatory findings. There's such a range of inflammatory findings that you can and can't find. And I think if we're not careful, we might get into a stage of overdiagnosis. But I think that concept of perhaps even what I tried to propose previously is, could we even use the SpA tool to create a sense check of this can go forward for a scan, this can't.
Yeah.
But that's, so that number one, that hasn't been done. But number two, we do have to again be slightly careful, because there might be patients we miss using that tool. And of course, we don't want to do the community a disservice using that approach. So I think it needs investigating and looking at, but blanket turning on inflammatory spinal protocol MRIs, I don't think would please our radiology colleagues that much.
No.
Thank you, Ross. Chris, did you want to come in on that?
Yeah, I'd entirely agree with everything you said, Raj. I think there's some work done by the Spinal Pathway for Best MSK Health, done by Mike Hutton and his team, working with Phil Robinson, who's leading the diagnostics group, and they've kind of very much echoed what Raj has said in terms of pick up, and a note in the chat about the false positives with spinal MRI. Particularly, so there's huge potential for overdiagnosis, and we know that there's a huge iatrogenic effect of overimaging. We cause a lot of long-term disability through overscanning people. So whilst I understand that it seems like a nice idea, I'd be really cautious, and I think the requesting in primary and community care I have no problem with, as long as it's somebody who is an MSK spinal specialist who can then interpret and manage that, manage the results, I think.
Thank you, Chris. I'm keen now to bring in Victoria Carter. Victoria, I'm delighted she's with us this evening. It works at NICE and is part of the implementation team. I know that NICE are currently reviewing the impact of the NICE guideline on spondyloarthritis. We can bring Victoria to the stage. Hi, wonderful. Victoria, great to see you. Thank you for joining us. Listening to the conversation, what are your reflections?
It's been really interesting actually to hear all the different views. Obviously, the guideline is now kind of 4 years old from when it was published, and from my point of view, I work within the implementation team, and obviously we usually focus implementation efforts at the point where guidelines are published, and that would be comms and any kind of looking at gaps or problems with implementability, etc. But there are kind of obviously groups like this that are kind of doing that work, are really useful, because what they've helped highlight along with all the audits to us is that it's highlighted us to do an impact report, which is looking at the data and kind of the uptake of our recommendations. And that's highlighted obviously some quite big challenges, specifically around the diagnosis. So that's what my kind of role is. I've been talking to lots of different stakeholders, and what we want to kind of do, I write a section within the report that's kind of looking at, let's highlight those priority challenges. So we're kind of showing that information, people are aware of it, and also highlight what support there is out there, if there's activities going on, and I've probably talked to a few people, my colleagues have, the first contact practitioners, etc. What is there going on that we can kind of highlight within it, so that people can access that support? And as part of the report, when we can do support with people, so if there are people kind of doing work out there that we perhaps haven't talked to, more than happy to kind of have a separate conversation with anyone about kind of the work you're doing, and either how we can support it in any way kind of as NICE, or also how potentially we can either link it to the impact report, or I can highlight it within that these tools or resources or support things are out there, and people can access that, because we do have a fairly wide reach, and alongside that we can do a lot of kind of comms work, etc. So yeah, more than happy to kind of talk to anyone that's been kind of talking about this, because it all sounds really, really positive. It's a long process to kind of get there, but some of the things that are in progress, especially things like the GP kind of pop-ups, etc. We've seen with other kind of guidelines and recommendations we've had issues with the past, that's been quite positive, just as a prompt to remind people. But we work with people doing kind of e-learning, things like that, to kind of just support and make sure it's kind of aligning with kind of the best evidence at the time, and linked pathways and things. So yeah, it's yeah, we're kind of doing that at the minute. It should publish early next year, but hopefully, you know, if when we share that, and hopefully it can get quite a wide reach, and people will see it highlighted within that, you know, it's something we need to look at. And there's groups, I mean, the report that the APPG did is referenced quite extensively within the report, because it really highlighted those kind of issues, alongside obviously some of the other reports.
Well, I'm delighted to know the APPG's report has been helpful to NICE, and also delighted that NICE has taken the time to review the impact of the guideline. I think it's a welcome development. How can colleagues here engage with you if they have any examples they want to share with NICE?
I'm more than happy for anyone to email me. I can put it in the chat after. And then, yeah, if anyone just wants to kind of drop me an email, more than happy to either have a conversation separately or by email if there's anything you want to send me that we can see, and see if there's ways of linking it within the report, because, you know, we can talk so far, but we don't know everything that's out there and everything everyone's doing. And, you know, this is where it's great to have the opportunity to kind of encourage people to come and tell us about that. And if we can help share that message in any way, or link up to show that, you know, it's kind of aligned with the guidance, then that's kind of what we want to do.
That'd be wonderful. If you could please give your details. I'm sure colleagues here will be desperately keen to talk to you. I'll now need to start to bring the conversation to a close as we really move towards the final point. Are there any final comments any of our panelists want to say, really? Any burning comments to get off your chest? It's been a great discussion, and as ever, we will write up the report of the meeting and circulate it, and the copy of this recording will be available imminently too. If I might now just turn to provide some updates from NAS that are relevant to all of this, and I'm going to just share my screen and hope that this works. Okay, can I just check that that can be seen? Yeah. Can you all see my slides? Can someone say yes?
Yes.
Yeah.
Excellent, great, thank you. Okay, I just wanted to say three things briefly. The first is to remind ourselves that we established this APPG with a very specific remit, which was indeed to provide oversight to ensure effective and widespread implementation of the NICE guideline that we've just been talking about. And a key part of the work at NAS to ensure the widespread implementation is our Aspiring to Excellence programme, which Dr. Wallace spoke about in her presentation earlier. I wanted to say that I'm delighted that this Friday we will be launching the first report from the Aspiring to Excellence programme, showing how the first 6 hospitals involved have managed to undertake, I think in the context of COVID, pretty amazing service improvements and data to demonstrate those improvements too. I'll be launching that report at an ARMA webinar on Friday at lunchtime. Huge thanks to ARMA for organising that, and we'll put a link in the chat to the ARMA website. Please do register and join this conversation where, on the back of the GIRF Rheumatology report, we're asking the important question, what's the role of patient organisations in driving improvement and supporting the implementation? So please do join us as we launch that report and discuss those issues on Friday lunchtime. Since we last spoke, we have launched our Act on Axial SpA final plan and route map with our solutions to achieve time to diagnosis of 1 year. I want to say a few things. The first thing is that, as you know, we launched at the report, but also the first part of our campaign, including this amazing website, I hope you feel, actonaxialspa.com, which provides a portal both for people who may be concerned they have axial SpA, as well as clinicians working in primary, secondary care and rheumatology services, which provide case studies, practical examples of how they can make improvements in narrowing that time to diagnosis to 1 year. We launched our awareness campaign, taking people on a journey from knowing nothing about axial SpA and its symptoms through to thinking about their symptoms, checking them online, and thinking about their GP appointment. We've had I think, a very successful social media campaign using comedy to reach an audience who know nothing about axial SpA. We've been working with singer-songwriter Talia Dean, targeting younger audiences, for example, our TikTok videos, engaging a younger demographic the people who are first experiencing symptoms, encouraging them to understand the condition, the symptoms, and if appropriate, consult primary care. We created the SPINE acronym to helpfully distill what is a complex condition into 5 key symptoms, and that's an important part of our public awareness campaign. I've mentioned the online symptom checker, which incorporates the existing validated inflammatory back pain pathway, back pain criteria. We've had over 1,200 people already undertake that. They get advice which they take to their primary care professional, which tells the professional where the symptom checker comes from and advises the primary care professional to consult the SpA tool and the NICE guideline. Also, thanks to colleagues who've helped provide new resources to help patients thinking about preparing for that first appointment with their GP to discuss their symptoms, and indeed preparing for the rheumatology appointment. So a whole new set of resources to guide people on from a state of unknowing to feeling that they know about the condition and empowered about what they should do next. So far, just in the first few months of the campaign, our social media activity has reached almost 500,000 people, and our video content viewed 375,000 times. As I mentioned now, over 1,200 people have completed the symptom checker, and we will follow up with those people to understand their pathway to diagnosis from there on in. And in a context where it's very hard for anything that isn't COVID related to get published in the health news, we're delighted to have had some coverage in the national press about diagnostic delay and some to bring into public awareness really what people can do if they think they have the symptoms of axial SpA. The next significant program of work that we will be launching on the 4th of January is our Axial SpA Primary Care Clinical Champions program. And both Denny and Louise in their presentation talked about the potential role that primary care champions have to play. So we will be creating a program that will create and support a cadre of around 20 Axial SpA primary care champions. They could be GPs, FCPs, a whole range of colleagues working within primary and community services. They're going to get some bespoke leadership development support, as well as structured training on the theory and methods of quality improvement, as we have with the Aspiring to Excellence program. They'll be supported through expert facilitators to implement local improvement projects, work together through a national learning network, and very much in the context of the Best MSK program in England, at least, feed back into the wider system and work with the named MSK leads within the regions and the integrated care systems. And very much with the aim of co-producing resources that will feed back into primary care education and training. So we hope that this will be a significant investment to raise the visibility of primary care, Axial SpA within primary care. We will have materials on our website certainly before Christmas about the program, but if anyone who would like to apply, we will launch our corporate applications on January the 4th next year. That's all from me, and over now to Tom.
Thank you, Dale. So that brings us to the end of this afternoon's or this evening's meeting. I'm very shortly going to have to go and vote. So you've been spared a long summing up speech by a politician. But I'd just like to say thank you to Louise, Denny, Abby and Chris for putting together the presentations this afternoon. They've been fantastic. Thank you to everyone who's taken part in the group discussion as well, everyone who submitted the questions for what I thought was a really interesting interactive Q&A discussion at the end as well. So there's been a really, although we're meeting remotely, it's nice that we've been able to have that sort of group discussion, group talk, in spite of the fact that we're not meeting in person. So look, I think what we've got out of today is a really sort of reiteration of the importance of working with the primary care to improve the identification of axial SpA and bring that delay to diagnosis down. But obviously we've heard some of the sort of the wider issues that are being faced by primary care at the moment, and which policymakers and decision makers are dealing with. I and the other members of the APPG are going to continue obviously working in this area and with our other work streams, and thank you, Dale, for the summary there. And we'll be taking these issues forward with parliamentary colleagues in the coming weeks. And as Dale said, there will be minutes from tonight's meeting will be shared with attendees over the next couple of weeks. But until then, and until our next meeting, thank you very much for coming this evening, and thank you for staying behind. I know some of you stayed behind after work to listen to this. So thank you so much for coming, and I look forward to seeing you all very soon. Thank you.